away from what the objective of a blood transfusion service is. And this is to do is really to develop an efficient system for blood procurement, that means to take blood, to collect blood, produce, process the blood, and then distribute the blood and blood products to the hospitals and patients that need these precious products. And to do this, we need to recruit and maintain sufficient, healthy, regular, voluntary, the point that we collect the blood to the point that we give the blood to patients, that is vein to vein, from vein of the donor to the vein of the recipient. And we also need to produce more and more blood and blood products to keep up with the development of the health system within the medical lab tech. They have already got a 3-year diploma training, but we offer another 6 months post-basic course to train them specific in blood transfusion. And we also recruit a number of scientists. These are people who graduated with degrees and so on. And we also provide masters. And the other thing that we also introduce, just have a pilot program in Hospital Kuala Lumpur, because it comes under the National Centre. We have transfusion team, where there are 2 nurses and 1 doctor. If this is successful, then we will implement it to the rest of the hospitals.
How do you screen the donors for phalanxes? Is it just before the donation, or you prior to donation?
You have to be a whole blood donor first. So this is the criteria. You have to donate at least twice a year. Then only we convert you into because the apheresis disposable bags are very expensive, right? So you don't want.
We know it's not anticoagulant therapy because we are not aware of this patient being on anticoagulant therapy. And generally, a patient is on anticoagulant therapy. The prothrombin time is usually between 20 and 30 seconds. So he's got a prolonged prothrombin time. And then the C3 stage then is exponential with each component that's activated. And so these anaphylotoxins promote the release of serotonin and histamine from platelets and tissue basophils, and this produces an aggregation of the white cells producing these lymphoemboli. So this is obviously, again, a very serious situation. Volume overload, the 4th of our possible problems here, also with special requirements that haven't been met, such as it should have been irradiated for a neonate or CMV negative, and that was overlooked. So, but these count as incorrect transfusions. Transfusion-transmitted infections, there were 3. No cases of transfusion-associated graft versus host disease. 2 post-thrombocytopenic purpura. 24 cases of trawling. 23 hemolytic transfusion reactions. 114 acute transfusion reactions. And these include what we used to just call acute antibody-mediated or delayed transfusion reactions. So these will include febrile reactions, for example. And this is another new category, anti-D, and that really doesn't concern people in this area of the world. This is where maybe anti-D should have been given to an RHD negative person and wasn't. The mortality in 2007 was the lowest ever. There were no deaths related to IVCT category. There was 1 death probably attributable to transfusion, and one case of probable Charlie in which the patient died. There were 3 cases in which the patient died and the transfusion reaction might have been contributory. And one was an acute transfusion reaction in a very sick 8-month-old baby, and that was due to FFP administration. And 2 hemolytic transfusion reactions in patients with multiple comorbidity, and so there's no real way of knowing whether those patients would have died anyway. And that's because they've found that a lot of the mistakes are made out of hours. Any unexpected discrepancies in laboratory results should be investigated fully and possible sources of error considered. And once again, failure of bedside checking of the prior to the transfusion seems to be one of the major areas of errors in transfusion. And again, this is generally down to inadequate training or inadequate competency assessment. So obviously any transfusion reaction should be investigated as a matter of urgency with the involvement of the consultant hematologist or transfusion specialist, as Jasmine said. So clinical staff, first and foremost, they must be able to recognise the transfusion reaction and know how to proceed. And that sounds very obvious, but if we look at delayed hemolytic transfusion reactions, for example, and they don't occur for a week or up to maybe 3 weeks after the transfusion, very often the patient's already gone home, and so they might present to a local doctor, and if that doctor hasn't been trained, they don't know the reason for the symptoms in that patient. So we know that there are knowledge gaps and lack of education and training for junior doctors, and I think we all have a professional responsibility to try to close that gap and provide education that is appropriate. So just for the last few minutes of time, I'd like to mention the other adverse reactions that we haven't dealt with yet. So an acute hemolytic transfusion reaction will generally present with fever and various other signs and symptoms of hemolysis. For example, a fall in hemoglobin reaction until day 10. So again, as I say, sometimes, unless the patient remains in hospital, they can go totally undiagnosed, and I think it's probably underdiagnosed and underreported for that reason. So if we quickly look at anaphylactic and severe allergic reactions, in anaphylactic reactions there's hypotension plus one or more of a rash, breathing problems, hives and so on, all during the transfusion or at least within 24 hours. But an allergic reaction is slightly different. There's an immediate risk to life during or within 24 hours of transfusion because of bronchospasm causing hypoxia, so the tissues are not getting oxygen, or angioedema causing respiratory distress. The anaphylactic type reactions is an immediate hypersensitivity response with a broader range of symptoms than allergic reactions, as I mentioned, but you can have loss of consciousness and very rarely death. But it differs from other reactions because you tend not to have a fever, but responses can occur even to tiny, even just a few ml of plasma. And I mentioned the 8-month-old that had a transfusion reaction due to FFP, and the same thing can happen with some of these patients having anaphylactic or allergic reactions. The mechanism is recipient IgE and or IgG antibodies which react with the allergens that are present in the donor plasma, or maybe the donor plasma contains IgE or IgG that reacts with an allergen in the recipient's plasma. And allergens can actually originate from within the blood banks, for example, ethylene oxide. So this is obviously a problem there. And the mechanism is that mast cells release histamine as the primary mediator of the reactions in response to the allergen antibody complexes. And then we have vasodilation and edema due to increased permeability, and they're generally treated with antihistamines. If there are repeated reactions, washed cells might be advised. If the patient is having pulmonary involvement, then chest x-rays are required to exclude Charling and blood gases in clinically hypoxic. A lot of these are due to IgA and anti-IgA, so testing for anti-IgA and IgA levels can be quite important. And a mast cell tryptase in the laboratory, as a laboratory test is available, is useful to distinguish between anaphylactic and allergic reactions. Just a mention of IgA, there's an estimated IgA deficiency in about 1 in up to 800 people, so it's more common than you sometimes think. The allergic responses are secondary to class-specific anti-IgA antibodies in people with IgA deficiency, and the symptoms can be very severe. There are patients with normal IgA but anti-IgA against kappa or lambda IgA light chains, and they will generally show urticaria, so hives, sometimes periorbital swelling, problems. Starch has been implicated, dextran and gelatin solutions. And the mechanism in these cases is likely to be related to IgA antibodies reacting with that particular or specific allergen. And again, this is a case from a few years ago in the UK where there was a 37-year-old female who had severe atopic eczema, asthma and a peanut allergy. She started the peanut allergy apparently when she was very young, and by the